These are great answers. Thank you everyone for your participation. Okay, I'm going to go ahead and lock the poll now and get us started. Welcome everyone, and thank you for being with us. I am Amy Etzel, Implementation Manager with the BRIE Collaborative, and welcome to the first of a 4-part Framework for Action webinar series, Mobilizing Collective Action Around Social Determinants of Health. On behalf of the BRIE Collaborative and the Washington Health Alliance, we are so excited that you could be here with us this morning and thankful for your commitment to supporting a more rapid acceleration of value-based payment models across our state. I've been hearing some of the words of yesterday's inauguration poet, Amanda Gorman, in my head all morning, and one line from her beautiful poem read, "A nation that isn't broken, but simply unfinished." She wrote these words, obviously, for a very specific point in time in our democracy's history, but I love this concept of putting hope behind something we often think of as broken and re-examining it rather than dismissing it as broken. So I ask you to keep this idea of hope and new ways of approaching the problems within our healthcare systems in mind as we come together to move our systems toward value and move toward a system that allows our patients and communities to thrive. Before we begin, just a few housekeeping items of note. You are all currently on mute and will be throughout the day. During each presentation, please feel free to write a question into the Q&A box at the bottom of your screen. Please enter questions for our speakers into the Q&A box and any technical issues into the chat box. We will be monitoring both throughout the webinar, but we will be looking primarily at the Q&A box for questions during that portion of our event. Additionally, this webinar is being recorded, and a link to the recording along with today's presentations will be emailed out to you early next week. You may have noticed the closed captioning transcription at the bottom of your screen. In the spirit of inclusivity, we will be using this feature in Zoom for all webinars going forward. If you would like to view and read the full log of this transcription, please look at the bottom of your screen and click on the far right option, View Transcription. And then the second option of the menu that pops up that will appear is View Full Transcription. This will bring up a dialog bar on the right side of your screen with a full log. All right, so let's dive into our presentations. Today, we're starting with Sarah Singleton, principal at Levitt Partners. In her role with Levitt Partners, Sarah serves as advisor to the National Alliance to Impact Social Determinants of Health, or NASDO, as well as advising clients throughout the healthcare sector on federal healthcare policy issues, including research and drug development, public health, and the Affordable Care Act. We are so thrilled that she could be here with us today to share some lessons learned through her work with NASDO and some resources from their multi-sector partnerships. Welcome, Sarah. I'm going to go ahead and get your slides ready.
Great. Thanks so much, Amy. I'm really delighted that the BRIE Collaborative and the Washington Health Alliance invited me to be here today, presenting from the other Washington. I'm based in Washington, D.C., so it's fun to talk with colleagues from across the country. I am excited to share with you today. I'm going to start with a little bit of just sharing with you about NASDO and who we are and what we do, and talk a little bit, some framing about social determinants of health and social need and level setting on some terms. And then I'm going to talk a bit about forming multi-sector partnerships. This is a really core piece of what NASDO is about, and we've gathered some learnings from our members. So I'm going to walk you through some of the elements that we think you should try to get in place to form a multi-sector collaborative. It can feel daunting, but I think if you break it down into various tasks, it's very doable, and there's lots of successful examples across the country. So to start with, who we are, NASDO, which is a mouthful, the National Alliance to Impact the Social Determinants of Health, is a group of stakeholders working together to build a common understanding of the importance of addressing individual social needs and social determinants of health as part of an overall approach to health improvement. So nearly everyone in the system has an eye on improving health, and we think that, very similar to the remarks that Amy was making at the beginning, to move towards health, social determinants of health has got to be a part of the equation. So if we can go to the next slide. NASDO was formed about 3 years ago by Mike Leavitt and Karen DeSalvo. Mike Leavitt was a 3-time governor of Utah and the Secretary of Health and Human Services at the federal level during President George W. Bush's administration, and then went on to form our firm, thus the name Leavitt Partners. And Karen DeSalvo was the former health commissioner in the city of New Orleans, worked in the Obama administration as the Assistant Secretary for Health, and is now the Chief Health Officer at Google. And Karen and Governor Leavitt got to know each other in the period of responding to Hurricane Katrina and the aftermath, which of course devastated so much of New Orleans in many aspects, including the healthcare system. And as they started talking about what they needed to do to improve health in New Orleans, of course, they had to put back together the hospitals and health clinics. But both of them shared a passion that it was more than just what had to happen in the health clinics, that there was so much that needed to be done in New Orleans before Katrina and exacerbated by the natural disaster there. And so they sort of had this shared interest in social determinants. Obviously, both of them went on to work other jobs, but when they were both out of government, they got together, put together a retreat of some of their like-minded friends and associates, and out of that, NASDO was born. So if we can go to the next slide, just to give you a snapshot of our members here, we have a number of health insurance providers, some national and some more regional. We have a number of healthcare systems, many of them integrated delivery systems like Intermountain Healthcare and Kaiser Permanente, and then also local or regional ones like RWJ Barnabas Healthcare. We have sort of public health and consumer stakeholders like the American Heart Association, the March of Dimes. We have social service providers like the National Association of Area Agencies on Aging. And we have a variety of other folks that are sort of doing interesting things in social determinants of health. So for example, Rethink Health, the De Beaumont Foundation serves as a funder, the Build Healthy Places Network is a thought leader. So it is a great group. It was, to me, I've been with Leavitt Partners and NASDO for about a year, and the opportunity to work with NASDO was the real draw for me because I thought it was a really exciting opportunity to engage with these people who all of them have some level of interest at a corporate or nonprofit level in social determinants, but are there for a bigger reason. It's not because it's going to save them a buck that they want to join NASDO. It's because they believe in a greater good and want to come together. And the variety of perspectives they bring, I think, is really valuable to our work. If you can go to the next page, just a moment more on NASDO to let you know what we do. We have sort of 5 areas in which we work. One is issue framing in a way that promotes action. And today, what we'll talk about, I think, is part of that issue framing. The second is elevating shared learning across communities. And I'm excited to talk with you today and then also to hear later in the presentation about what's happening in your state. Working on shared approaches to measurement and evaluation so that we can sort of build the case for why to invest in social determinants and in the long term. Encouraging data and technology information so that information is shared, particularly between the healthcare sector and the social services sector, to make it easy on the client or individual served by the system to protect their privacy and to make sure that their needs are being met without being asked over and over again. And then finally, promoting a supportive policy environment at all levels of government and the private sector. And we obviously have a brand new administration, and they have a real focus on health equity. It's been one of the early things, including in executive orders yesterday. So we've seen good progress over the past few years in terms of the Department of Health and Human Services, trying to allow some flexibility within their federal funding streams, like, for example, through Medicaid and through Medicare Advantage, to address people's social needs. And I think we're going to see an even bigger focus in this administration because of health equity being one of the top presidential priorities, combined with where we are, of course, in the COVID crisis. So it's a great opportunity from a federal policy perspective to set in place flexibility in funding streams and other ways that you can enable states and localities and private sector actors to sort of go forth and address social determinants. So let's go to the next slide. So I think I'm speaking to a crowd that shares this viewpoint, but just to level set, when we talk about health, it's foundational to economic vitality, to business competitiveness, to personal achievement. We all know that healthcare costs are competing and eroding investment in other social and societal goods like education, public safety, and transportation. And that, of course, improving health overall requires more than great medical care, because health results from the environments in which we live, learn, work, and play. So we can do fantastic high quality medical care in the clinic that's accessible, that's culturally competent. But if it stops only at what happens in the clinic, we are not going to probably move the needle enough to produce health. We have to improve the experiences in communities, and that will be more than the best performing medical system, although the medical system has a large role to play, we think. Can we go to the next slide? So just to level set on terminology so that when I say things, we're all clear what we're saying. There's of course many definitions, there's not only one. But in this presentation, when I say social needs, I'm talking about the immediate non-medical needs of an individual. Efforts to meet individual social needs are things like someone is experiencing a shortage of food, and so you may get them a home delivered meal, or someone does not have access to transportation to their medical appointments or for other things like to go to the grocery store, so you might help them with a need like that. Or they are having housing instability, you might make a referral to a housing agency, or better yet, if possible, help them with short-term rental assistance or something like that. The social determinants of health are the conditions in which people are born, grow, live, work, and play that affect healthcare outcomes and risks. So it's not just being hungry one day, it's the whole neighborhood you work in, live in, or work in. It's the conditions in your environment, all of which affect us from in the womb throughout our whole lives. And so efforts to address the social determinants of health prioritize addressing those underlying social and economic conditions. So rather than just meeting someone's need today for a meal, which is of course important, and I'm not belittling that, it's looking at the systems in place and saying, this whole neighborhood has a shortage of food. Perhaps that's because they don't have a grocery store. What can we do to improve their access at a neighborhood level, or bolster the systems so that food banks are available to them? So it's that move from one person to a more systemic level. We can go to the next slide. I'm assuming that many of you have probably seen a chart like this. There's several sort of notable graphics. This is just trying to show what are the drivers of health outcomes. And as you can see in the sort of bottom right gray quadrant here, we have clinical care. So that's what happens when you go to the doctor and get clinical care. But that's only 20% of what's driving your health outcome. 80% of it is based on other factors in terms of community safety, education, clean air and water, tobacco use, diet and exercise. So there's a whole lot driving healthcare, your health status, beyond just the healthcare you receive in the clinic. Next slide. And just a couple more terms to level set on, particularly because these are very timely right now with the Biden administration's priorities and what we've seen in COVID. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. So it requires removing obstacles in the way, such as poverty, discrimination, powerlessness, lack of access to good jobs, safe environments, etc. There are other ways to define it, but I like this one from Robert Wood Johnson Foundation, because I feel like focusing on that opportunity and giving everyone that opportunity sort of makes sense to me. Another term that you'll often hear is health disparities, which is a particular type of health difference that's closely linked with a disadvantage and often adversely affect groups of people who've systemically experienced adverse conditions. So health equity is the principle that underlies a commitment to reducing and hopefully ultimately eliminating disparities in healthcare. So there's a connection point between them, but you'll see in the research often talk of particular health disparities in certain areas, whether it be heart disease, cancer, diabetes. And health equity sort of zooms out to those larger conditions and trying to level the playing field there. Can we go to the next slide? So I think our vision in NASDO is a move to first address people's immediate social needs, because when people need help today, we should be there, but to eventually move to a more broader systemic look at addressing social determinants of health. When you look at what one organization can do, whether it's a hospital system or a health insurer or a particular business, they can often positively impact an individual's social needs through monetary contributions or partnering with a community provider. And that is important and needs to happen. But if you're looking at systems level change, one entity like that, for example, if it's a major healthcare institution, they may be able to start making a dent in some of the social determinants of health. If they really invest their time and resources and partner with the entities that would provide those services, they can start to move upstream there. But to have the biggest impact, we really believe in NASDO that multi-sector solutions are needed. And that's sort of one of our major organizing principles within NASDO and what we are trying to work towards. Can we go to the next slide? It's easier to say that than to do that. One of the reasons is that structural considerations often lead to underinvestment in social determinants of health and inefficient approaches. There may be large benefits overall to reducing the number of people in prison or making the streets safer or improving the environmental conditions in a neighborhood. But those benefits are may not be fully realized by those who are asked to bear the upfront cost. And so bringing together multiple parties is one of the ways that you can get at making that a more even distribution amongst various players. Can we go to the next slide? So why is it multi-sector, the approach that we advocate for? It's because when you pull together partners, they are all going to have very different assets and strengths and abilities. And it gives you the opportunity to create shared incentives and drive coordinated investment in social determinants. And we're starting to see examples across the country of that. So to make that lasting impact, we think that that's really the approach. And we sometimes use the word collaborative, sometimes use alliances. There's different terms for it, but we think ultimately those collaborative approaches, including multi-sector partnerships, are what have the potential to create shared incentives and tackle the diverse and unique set of challenges that each community faces. Can we go to the next slide? So I've outlined here a number of factors for success. This is not meant to be an exhaustive list, and we're going to get into some of this in a little bit. But we've sort of identified that one of the most important things is having a shared vision for what you're trying to accomplish. Another is to have a clear avenue for collaborative action. So you may unite around the problem in a community, but you have to have decided on a way to work together on it. You need to have management of this multi-sector solution so that you can have a long-term roadmap and you can draw on the strengths of each partner. We think it's often best when you work public and private sector together. You may be able to find the funding from the business community or from the philanthropic community, but government programs, whether they're at the federal level, state level, or local level, are often really important to filling some of the gaps. So if you try to do it private sector alone, you may sort of run into a roadblock and not be able to succeed as much as you might otherwise. We think that cooperation between stakeholders that may not usually work together is important. They probably shouldn't have explicitly competing interests, but they may have divergent interests, and bringing them together brings a lot of power if you can find that common pain point. And then of course, in the long term, you want it to be sustainable and scalable. And together, those things are how you get to the maximum impact, which we define as systems change, sort of back to the point I was making before about moving beyond just one person and one need to systemic changes. Go to the next slide. So I was going to run through here a number of focus areas for developing a multi-sector collaborative. And it's always hard to put this on a graphic because they're not, it's not that you have to go from one to the next in exactly an order. I do think that there's some logic to presenting them in this way, but you may pick up on certain pieces before others. In full disclosure, we at NASDO are working right now on a compendium of resources for people, organizations, and communities that are interested in multi-sector collaboratives. And so these are the themes that we are working off of based on the experience of our members and discussion over many months about the kinds of things that were important to them when they've been successful and frankly, when they have not been able to get collaboratives going. These are the factors that they've considered in forming their multi-sector alliances. So I'm going to tackle each of these briefly. So if we can go to the first one, informing alliance. There's a couple different things. So the first critical element is, and speaking specifically here about trying to impact social determinants of health, is agreeing on a common pain point and setting a vision. Each community is unique. The problems and pain points will look different depending on their social, political, and economic factors. And those will then create unique health challenges in the community. So it might be that childhood asthma is the particular concern or diabetes is the particular concern. So whether you're organizing around a particular disease state or you're organizing around a neighborhood's needs, you want to localize it. And the most effective alliances are those that identify pain points felt across many sectors and stakeholders in the community. They have to have a vision for how the community would look absent those challenges, and articulate a vision that solidifies the purpose of the multi-sector alliance, including a diverse set of stakeholders, gathering multiple perspectives, importantly, including those from the community members themselves, can ensure that the alliance vision is representatives of the community's needs and goals. And focusing time early on gathering those insights will provide the foundation for a strong and effective alliance. The next thing is figuring out the composition of your alliance. So we often think about what kind of stakeholders you want, and there's no right answer. There's no specific formula about which stakeholders you want, but the kind of factors you would consider are the stature and influence they have in the community, representation from both public and private sector, diversity in backgrounds and perspectives, and the roles and responsibilities that a particular representative of an organization has within that entity. Healthcare and public health in particular, I think, have an important role in building alliances to impact social determinants, but they're not the only stakeholders. Other ones you might consider are the business sector, individual companies, businesses groups like the Chamber of Commerce, local government, including various elements like public health, social service, the human service sector, economic development, sometimes even safety and justice, or community-based organizations like faith groups, or particular social service providers like food pantries and nonprofit legal service organizations, et cetera. So that's sort of the first group here. Let's go to the next slide. The second area we focused on is building a strategy, which is about identifying the community needs, strategic planning, and assessing the impact. So first, you'll want to think about your governance. The impact of an alliance is highly influenced by good governance. And there's not one way that looks, but you would want to do things like outlining member roles and rules for engagement, and make sure that you're, sorry, I'm just looking. I feel like I'm on the wrong slide here. Can we go back one? There we go. Okay.
That's my fault. I apologize, Sarah. Thanks for calling that out.
No problem. Having good governance prevents the opportunity for misunderstanding between alliance members, and make sure that you have streamlined systems for communication and decision-making, and defining the structure and rules of engagement for the alliance. Leadership is also a big piece of it, as is probably the case in any time that whether it's a single organization or multiples come together. But in particular for an alliance leader, They have the responsibility for carrying out the alliance vision, goals, and plans, and often acts as a convener of the alliance, although not always, and can also serve as the backbone organization. When I say that, I mean that they help create the vision and strategy, but also some of the operational aspects, such as coordinating, acting as the central point, perhaps managing the money, etc. Organizations in healthcare often can play that role, and public health can too, because they typically have a strong understanding of the community's existing health system and structure, and they're likely to understand the gaps in them. But it's not always the case that that's where an alliance would best be organized as the backbone organization. Then the last piece I wanted to cover here was building an aptitude for collaboration. Really to harness the collective power for an alliance, there have to be mechanisms in place to build and maintain that collaborative spirit. Sometimes the stakeholders, depending on how wide the membership is, have similar or parallel work streams. And in some cases, they may actually be direct competitors with each other or have adjacent interests. And those can be effective in both schemes as long as they have collaboration around the clearly defined goal, as we talked about at the beginning of this, and coordination to increase their ability to successfully impact change. We can go to the next slide. On building strategy, this third area. So first is identifying the community needs and objectives. The goals have to be practical to facilitate an alliance. Making a goal that is too far out, while sometimes aspirational and inspirational, can lead to frustration, because if you're trying to affect a trailing outcome like lowering the death rate in the community, you're not going to see the impact of that for years, probably decades, and probably at a really small level where it would be hard to feel wonderful about the outcome. So identifying the need and objective in a way that feels measurable, but also likely to notch success along your belt along the way is, I think, an important part about being successful. Strategic planning is probably always important for individual organizations, but for an alliance in particular. The most effective strategic plans are those that have tasks that are actionable, measurable, and have set objectives on an established timelines that includes things like the community needs, the vision, the alliance goals, etc. And then, of course, assessing as you're going along. You're not going to get better if you don't have a method in place to seek feedback and to assess yourself. In and of itself, an assessment doesn't do anything unless you make a plan to act on it. So that's another piece of it, is making sure that you have a plan for how you're going to do it and then what you're going to do with that information when you get it. Let's move on to the fourth category here, which is building capacity. A piece that's really important here is authentic consumer and community engagement. Community engagement is not a single static task. It's not a one-time thing to check with the community about what they need and to go off and work without consulting them. It has to be embedded in every step of an alliance effort, from the point where you're identifying the common pain point to your strategy about who you're going to engage in the community, to even how you're going to measure, as we were just talking about, the impact. It can be done by working with individual members of the community and also using the knowledge of the alliance members as representatives of their community. There's various techniques for this. There's community mapping, there's participatory community assessments, there's open town halls. There's lots of ways to do it, and using the established relationships that the alliance members have in their communities is a really good way to make sure that they are in touch with those that they are seeking to serve. And the last piece here is data and coordination. It's important for the alliance to identify relevant and robust data sources. So much of data collection lags behind, as all those in the public health world know. So if you're looking for data from the CDC, for example, on how you're impacting one of the conditions that they collect data on, it might be a long time until you can get that information. So is there a better way at the local level that you can collect data to know that you're having an impact, and to help your multi-sector alliance in the long term show its funders that it's having value? It's pretty hard to sustain things if you don't have somewhere along the way to show that you're improving. Let's go to the 5th category here on sustainability. So financing is, of course, always a concern. You need financing to sustain something for a long term. And we could probably talk all day about that, because I know it's a real pain point for particularly nonprofit organizations and government sources. But thinking about financing models that have that shared incentive and shared benefit is probably the way that you're going to achieve that in the long term. And then developing policy and advocacy capacity to sustain your changes over time. So working, for example, with the local health department or the city council to embed in the processes that they have that change for the long term. Let's get to the final category here about taking action. Sometimes you'll want to develop your own intervention, or sometimes you'll want to take a model that already exists. Both are completely valid ways to approach it. And you'll want to have intervention assessment as part of that. There's a number of tools available. And so using one of those standard tools can help you identify whether your intervention is working as you intended. Next slide. So I know I'm running up to my time here, so I'll be very brief. I thought I would give just a couple of examples, and then I know we're going to actually hear about a particular accountable community for health, so I won't spend much time on that. The Maricopa County, Arizona developed the Arizona Healthy Arizona Worksites program, where they partner with the local Chamber of Commerce and the Blue Cross and Blue Shield Foundation to improve Arizona's health overall. The focus is on employers, so businesses in their role as an employer. And there's a benefit both to the obviously overall community's health, and they've made it sustainable and of interest to the business community by focusing it on the benefit that they will receive from healthier workers. Another example I wanted to highlight was Allegheny County, Pennsylvania, and their Live Well Allegheny program, which is led by their local health department. And they've tried to find areas of common ground that can affect a community health. They ask businesses in their communities to take a minimum of 4 action steps along one or more of a few categories, including buildings and workplace environment, policy integration, health education and screening, leadership, commitment, and employee ownership. And their 3 main priorities areas are reducing cigarette smoking, increasing physical activity, and improving nutrition. And they've purposely set up their program so that you can take a business, for example, can take a small step and have an early positive experience. So for example, one of their local grocery chains saw the opioid crisis in the community as a major concern. And so they had set up take back boxes and disposal areas in public bathrooms. And so in little ways are working together and can then begin to work more systemically. And then of course, the accountable communities of health model is something being used across the country in various ways. So I won't talk too much because I'm excited to hear more about the local accountable community of health. So with that, I think I will wrap here.
Okay, thanks so much, Sarah. Really appreciate the wonderful overview of the work of NASDO and some of the key phrases and frames to help us think about that. We've got a couple questions in the chat or in the Q&A, and I'm also seeing that there's some questions in the chat, but if we could hopefully have people put them in the Q&A, then I can follow them that way. So the first question is, as you're talking about, and I know you talked about Maricopa and Allegheny at the end, but specifically how does one go about identifying community needs and then actually creating a coalition to drive action? So can you talk a little bit kind of more specifically about how one who wants to do that could start that process?
So there definitely are a number of tools available to do community needs assessment. So if the interest comes first from having willing partners, you can use one of the formal tools. I would say in practice, though, it often comes together more around having seen a need together and then trying to gather those together, gather the relevant organizations together. And it's, you can start with the biggest need in the community, but that is a tall task to identify what the biggest need is. I would say the ones that I've seen that are most successful often start with the need that's causing the most pain right now, which doesn't mean that it's the biggest need. It doesn't mean that it affects the most people, but it could be the thing that is costing, for example, the health insurer the most. So could be a small number of people experiencing homeless, but they're extremely expensive for the health insurer. And so that might be where they start. The other thing is they may have just a good relationship through other realms. So for example, one of our members is Intermountain Healthcare, and they have a good relationship with the United Way. And so out of that, they decided to have a partnership, and United Way had a different sense of what some of the local needs were than the healthcare system, because while people might tell their individual providers what kinds of social needs they're experiencing, it's not always systemically collected. And so working with the United Way, where they say, this is what people are coming in for, this is what our data systems are collecting, kind of gave them the path for how they should focus locally.
Great, thank you. So as most of you or some of you on the call know, this whole webinar series started with the first webinar that we had with Dr. Don Berwick, who talked a lot about the moral determinants of health. And wondering if, Sarah, if NASDO has sort of tried to incorporate sort of that moral determinants of health piece in your work.
It's an interesting question. There are so many different terms, and I wouldn't say any of them are right and wrong. It's actually been a subject of great debate for us over the past several months, particularly this idea of, should we focus on health equity instead of social determinants of health? And I'll tell you what we decided within NASDO is that we need to talk about health equity a lot now, because it's high on people's minds and it's very important. And part of getting to health equity is addressing social determinants of health, but it's not the only thing that you'll need to do. And so we decided we couldn't just sub one term for the other, because they're not quite the same. And particularly because we aligned around this concept of social determinants a few years ago, and that became our organizing principle. We didn't want to leave it, but we recognize that there has been an evolution and we need to live within the times that we're in. And it's important to all of our members too. So trying to sort of do both.
All right, that makes sense. And then I want to let everybody know too that we're going to have a couple more questions with Sarah, and then I'll introduce Nick, who's going to talk a little bit about the social determinants of health efforts on the BRIE collaborative side. And then we're going to have Allison Polson, who's the executive director of Better Health Together, talk a little bit about, again, sort of accountable community of health within Washington State and example. And then we'll have some Q&A also at the end. So please keep the questions coming. So a question also around the genesis of the alliance or the collaborative that comes together to solve a problem. So have you seen it be more successful if it's an alliance or a group of sort of members that decide to do something? Or is it more from the community that helps, does it matter? And just sort of looking to see, is there a model that really does drive a better sort of community effort?
I wouldn't say that there's one best model out there. I do think it can be a challenge if the reason that people got together was because there was one particular funding stream open, through a philanthropic cause, and you decide to put together a group to address, let's say there's an announcement for diabetes prevention. So you put together the groups to do diabetes prevention. And then that funding stream goes away after that grant period of 3 or 5 years. Unless it was more that brought you together, I think it's pretty hard to sustain those things. And I hear that challenge from healthcare systems in particular, because they're sort of grant oriented and are used to getting money that way. And I think it can lead to disappointment in the community, because if we're talking about really doing a good job on diabetes prevention, we want to do stuff at the community level. It's not just giving someone access to nutrition education. You want to do bigger, broader things. But if you just get going with the community and then that dries up when your funding source dries up, it actually, I think, can backfire in a way that harms you for the future, because you engender mistrust if you did a good job of engaging the community and asking them what they need, and they tell you, what we need is better, safer places for kids to exercise outdoors, and we need more access to food, and then you cut that off when your funding source dries up. So that to me is the one biggest pitfall. It's not that you shouldn't take those funding sources when you can find them. I understand it's hard and you've got to take the money when you can get it, but you need to build something that lives beyond just that as your organizing principle if you want it to last for the longer term.
And as you're thinking about asking the community what they need, have you, you said that there's some tools that you can use. Have you seen in sort of practice an opportunity or a really good model for that? Or like one thing that you see over and over is a really effective way of engaging community? Because it seems like sometimes if you choose one sort of community organization, then you get that particular feedback as opposed to sort of a broader range of community voices. So just curious what you're thinking about that.
I'm aware of some specific tools, and I'm happy to send those to you as follow-ups, but I would say just as a general principle, you do want to find that mix of having individuals and then also organizations that represent individuals, but relying on just organizations can be a pitfall because you may assume that the perspective they bring is broader than it is. The other thing is sort of the idea of really authentic co-creation, that they're there at the beginning, that it's not a fully baked policy and plan and you have just a public comment period at the end where you can check the box that you had community engagement, but you didn't authentically ask people to start with what they needed and what they wanted. So, and it's challenging to do that. We at NASDO have received a grant from the Robert Wood Johnson Foundation that's about creating a set of principles for the healthcare system's role in achieving excellence and equity in healthcare. And authentic community engagement is a very big piece of what we're expected to do. And we're right in the midst of it. And it is fun, but it is challenging to figure out how to do it. Asking people who have limits on their time and resources to come and give you their time and resources to tell you what they need is challenging. It's slow, it takes creative ways of doing it, it requires flexibility. So talking about it is easier than doing it in practice, I would say.
Sure, and I think that there is a movement in the philanthropy world to actually pay communities and individuals for their time when they are mostly educating the foundation or the organization that is then taking that information and doing something with it, and then making sure that that information gets back to the organization that actually gave you that information. I think it's moving in that direction, which I think is a good thing for everybody. There's a couple of other questions, and some of these we will get to, and some of them are very specific. Someone did ask about the slides. We will make those available. There's something about, we're running into some challenges around partnerships and data sharing. And there was another question about sort of measurement and evaluation. And I'm wondering if you could speak to sort of some of the challenges with firewalls and PHI and HIPAA and all of those things that we know make things a little bit more difficult to understand impact and how you're doing with individual organizations and communities.
It is a challenge. I will say that people often assume HIPAA is a barrier, and sometimes it is, but oftentimes big bag HIPAA is not actually as bad as people think it is. But protecting people's privacy and respecting their choices is the really important principle. So I think sometimes people get overly fixated on one particular federal statute and set of regulations and lose sight of what they are there for. You want people's information to flow when they want it to flow, and you want to make it easier on the provider side. But incorporating all the pieces together to make that happen, it usually does take a lot of upfront work and a lot of agreement between the entities to do that. I tend to think, my sense is that the desire to sort of hold on to the data tends to be a bigger concern between competitors in the same industry than when for example, a healthcare entity and a social services provider want to share information, because the healthcare provider is not going to be as worried that the social service provider will take their role, because they have really different incentives and services they'll provide. So I think it can be harder when you're asking players in the sort of same industry to be the data sharers.
Okay, great. And with that, so keep the questions coming, and we'll follow those as Allison is talking, and then tee up more questions for both Sarah and Allison. And with that, I'm going to introduce Nick Locke, who's the program coordinator at BRE and is leading the BRE Social Determinants of Health work. And he's going to share a little bit about that. Thanks so much, Nick.
Great, thanks, Teresa. And thank you, Sarah, for sharing your expertise with us today. And I also really appreciate seeing all of the engagement from everyone who's attending and investing your time in social determinants of health. I'm really excited to see what we're doing and excited to see this movement towards building a more equitable healthcare system. So my name is Nick, and I'm a relatively new program coordinator at the BRE Collaborative. And while we transition between our speakers today, I'm just going to share a little bit about what we're doing at the BRE to mobilize some of this collective action around social determinants in Washington State. I think Sarah did a great job laying out a framework for building these multi-sectorial collaboratives. And at the BRE, we've recently embarked on a project that kind of echoes or kind of mirrors those steps. So I don't have any slides, but I hope I can be engaging enough over the next 3 to 5 minutes. So a quick background, the BRE Collaborative is a public-private partnership created by the Washington State Legislature in 2011 to ensure that all stakeholders have a voice in improving quality, outcomes, and affordability in the health system. In the past, the BRE's created work groups and addressed topics that include suicide care, opioid prescribing, and shared decision-making. Just last summer, the BRE specifically embarked on an ambitious project to research and recommend evidence-informed assessment of and strategies to address social determinants of health. Our first priority was to engage as many stakeholders as possible in both the healthcare and the social sector. So we formed a work group that consists of providers, plans, purchasers, patient advocates, community organizations, and a few more public representatives, including schools and the Healthcare Authority. At our first few meetings, the work group discussed our common challenges as well as some of the unique resources that our different communities have to addressing social determinants, and we were able to develop a shared decision for the topics that we wanted to address in future recommendations. Since November, we've been spending each month working through each of those topics, kind of addressing a different piece of the social determinants puzzle at our work group meetings. We started by discussing different types of screening tools and domains, and then thinking about what clinical workflows might look like. And then this month we were able to move into data systems and interoperability, which I am seeing from the questions is a big topic for everyone here as well. And in the future, we're trying to discuss referral management, closed loop referrals, the roles of health plans and purchasers in this work, and making sure that we center equity around social determinants. In addition to our work group meetings, we've also been conducting a few key stakeholder interviews with some of our cross-sector partners. Some of these partners that we've already talked to include a few of Washington's accountable communities for health, some hospital associations, and some tribal representatives as well. And even when we're talking with our diverse group of stakeholders, often we come back to similar themes. We find that there's definitely a renewed understanding and interest in health inequities right now, and there's sort of a movement gathering of interest in this topic, but also people are facing similar barriers, which include the need for more health information technologies and better funding mechanisms in order to really dive into this work. And I think another topic that keeps coming up is just that importance of creating trusting relationships at every turn. In fact, at the end of each of our stakeholder interviews, I like to ask our stakeholders what they think the most important social determinant is in their communities. And just twice earlier this week, I was told by some of our social sector partners that the most important concern they hear from their communities is a sense of belonging and a sense of community. And I think that really ties into this work, because if we're going to succeed in mobilizing collective action to address social determinants, we can't forget the importance of building those connections and fostering trusting relationships. And it's not just between patients and providers, the people asking the questions, but it's also between our diverse healthcare and social services sectors. We need to create that trust that comes, especially as a healthcare sector. I know a lot of us here are from the healthcare sector. We really need to do the work to create those trusting relationships and reach out to the social services sector. So I'm hopeful that the work that we're conducting at the BRE will be able to move from mobilizing cross-sector partnerships and into taking sustainable action. We're continuing working on some of the research and conversations throughout the end of June 2021. And by then we hope to have produced our recommendations and best practices for Washington State. And then we'll see from there if we're able to move into some implementation projects. But speaking of Washington State cross-sector collaboratives, our next speaker today is Allison Poulsen. Allison's the executive director of the Better Health Together Accountable Community of Health, which serves Eastern Washington, including Spokane. Allison has over 20 years of nonprofit and leadership experience. Before leading Better Health Together, she served as the executive director for 6 different Northwest nonprofit organizations, leading them through significant change processes to better meet community needs. And today, Allison's going to describe how Better Health Together leads regional community partnerships to address social determinants of health, which is demonstrating the power of our collective action. Thank you.
Thank you so much. It is great to be with everyone and to follow Sarah. I have to say that BHT has sort of approached this in a pretty organic and generative way, and a lot of the elements that Sarah was commenting on are actually present. So I wish I had had a little more thought to structure this to be like, when she said this, we're doing this. So this is a little more of a portfolio approach for us, but here we go. Okay, so just a quick primer on Better Health Together. We serve 7 Eastern Washington counties plus the tribal reservation of the Colville, Spokane, and Kalispell tribes. We organize our work into sort of 2 key buckets. The first is our accountable community of health, where we are leading our region's portion of the Medicaid 1115 waiver. And most of our kind of cool social determinant of health work has been funded out of the waiver. So I'll spend most of my time there. We also are in the process of really thinking about what comes next after our Medicaid waiver, and are starting to do more and more thinking about our community hub role. And the purpose of the hub really being this idea around demonstrating the value of multi-sector collaboration to solve our most pressing community issues. The work that sits in there right now is related to our Navigator network and helping people get connected to health insurance. We've just launched for our region a COVID care coordination hub, and then some efforts with a Better Health Through Housing program with Commerce, and some work on True Blood. So good stuff happening on this side of the mountains for sure. I also wanted to just level set a little bit on the 1115 waiver. Looking down the list of who's on the call, I think most folks are pretty familiar with the Medicaid waiver, but for the sake of keeping us moving along here, we're in the 5th year of a 5-year CMS waiver for the state of Washington. The waiver is divided into 5 key areas. One of those areas is accountable communities of health, and using that as a community transformation mechanism. And so you'll see on the map here, BHT is one of 9 ACHs in the region. I see I've got a couple shout outs to my ACH colleagues who are on the line here with us. And we all really pride ourselves in the local approach of how we are implementing the 1115 waiver. But I think there's some real commonality in how we are focused on things like value-based contracts, integration of physical and behavioral health, how we're getting to this whole person health model, whether it's through SDOH or a broader view. And each organization and each region really has a intentional focus on how we are addressing health equity and health disparities overall. And increasingly, I think the ACHs are being seen as a mechanism for action, both for regional convening as well as a avenue for state activity. So for BHT's Medicaid waiver transformation, we have 4 project areas that we're working on: integration of primary care and behavioral health, chronic disease management, opioid, and community-based care coordination, which gives us lots of opportunity to sort of play in the social determinant of health space. We have thought about how we organize this Medicaid transformation work really into 2 kind of buckets or approaches. One is through each of our county-based health collaboratives. And those collaboratives are comprised of just a number of the folks that Sarah said, this is who you'd want to have in your social determinant of health affinity group, but it includes the healthcare system, the public health system, our social determinant of health friends. Most of our collaboratives have active engagement from the education community, our county commissioners, criminal justice, and even in Ponderay, the local newspaper plays. So we like to think about this work really being connected to who do you need at the table to make your community healthier. And then the second stream of work we have is really through our performance-based contracts. And so we currently have 82, I'm a little overwhelmed by that number, but 82 contracts in place right now. And those are related to these 4 project areas, plus some evolving work that we have around equity, criminal justice, social determinant of health, and tribal health. To date, we've earned about $50 million, and we have a funding model where we're distributing about 55% of those dollars to our providers, 30% to regional infrastructure. That's really where the SDOH work lives. We've set aside 10% of every dollar that we earn as a region into a community resilience fund. And BHT is a lean, mean administrative machine trying to really limit our overall admin dollars to 5%. So it is exciting for the region, especially I think in Eastern Washington, that tends to be a fairly under-resourced community, to have this kind of funding available to do some really good collective work. Which really leads us to how we started to think about, or the evolution we've been on, or journey we've been on for our Medicaid waiver, which at the outset, we knew we cared a lot about social determinant of health, but we really had this vision to, we've got to make some core investment in the healthcare delivery system. And I think we weren't quite sure what was that linkage gonna look like. And so my intent here is to just show you a number of elements that are present in how we're thinking about this work. In this, I think we really spent time early on in the waiver being clear about where the healthcare delivery system was contributing to overall health and all of the other things that get healthy. And I don't know if this is unique to Eastern Washington and our sort of frontier spirit, but we like a lot of local control. And so as we were envisioning how we wanted to do this work, we knew we wanted to get as local as possible to have impact. So in thinking about this, we started to design our overall waiver strategy with a pretty core vision around how do we get our healthcare providers ready for more value-based contracts, and this sort of speculation that if we had more control of those funds, maybe we could make some of these needed investments. So our initial social determinant of health work, and I've learned something new today from Sarah's presentation about, was probably more focused on social need, which was housing, food, and transportation. And so you can see in here a number of activities that we have organized into building capacity and strengthening partnerships overall. I'm going to highlight a few of these for you. So first, in building capacity, we thought it was really important to stay focused on the core of the delivery system. So we have just gotten through, I guess, probably halfway through almost, our year 2 contracts with 36 of our primary care and behavioral health partners. That represents about 95% of the Medicaid delivery system in the greater Spokane region area. And in those contracts, we really structured them, one, so that we made some early investment in providers so they had the working capital that they were going to need to be able to move the work along, but also an ability to have some individual work, like this is what your organization needs to meet our goals around integration and chronic disease management and value-based care in our pay for milestones. And then in our pay for achievement strategy, these were really activities that we saw, these need to start being present across the region. And then we knew early on we wanted equity to be integrated into our work. And I'll make a few comments as we move along about how our equity work has really evolved. So these contracts were set up in a 40-40-20 performance-based structure. I want to highlight the pay for achievement component of this. And you'll see here sort of a list of activities. And so providers had a chance to choose 2 or 3 of these activities in year 1, 2 or 3 in year 2 to work on. And this was sort of our dancing into some SDOH work. So one was folks could focus on universal screening and follow up for SDOH, and 2 around care compacts with a social determinant of health partner. We thought this was an interesting way for us to see, well, how many providers are thinking in this direction? What kind of capacity are we going to need to help develop? And we'll see what happens. Well, after year 1, we were just unbelievably delighted with the 20 new care compacts that were collected amongst these 36 providers. 8,000 of our Medicaid members had some sort of service from a community health worker or similar type of service provider. And we conducted 7,700 SDOH screenings for Medicaid clients. So this really gave us, some promising practice about sort of how the healthcare system was starting to think about this. And we're just seeing growing interest in our providers to be adding more care compacts and doing more screening moving forward. So that feels positive directionally for us. What we did see through that process, both on the healthcare side, but also on our social determinant of health partner side, was there was an ongoing need for learning, skill development, best practices sharing. And so some of our best attended learning cohorts for our primary care and behavioral health partners were around SDOH connections overall. And I think this also ties nicely back into Sarah's presentation, a high interest in how we build data and outcome measurements to build up the case for this. And I think while we have not figured out the silver bullet of how to do that exceptionally well, I think there's been a great interest of our partners in that way. Those first sets of learning cohorts were really focused on the healthcare sector. And what we've seen as we've started to release funds and build deeper partnerships is our social determinant of health partners need an equal amount of capacity building. So in March, we'll be launching our SDOH learning cohort. And you can see several of the key topics that we think will be of great interest to those partners. The next area, and I won't spend too much time on this because this is probably our favorite mechanism that we have built and just see so much potential. But each of our counties have a county-based health collaborative comprised of the folks who you need to make people happy. And we spent the first couple of years just making sure those tables were sort of appropriately set and the right folks were in those conversations. What has transpired since then was sort of this desire of ours to let's see what these things could do. And so in 2019, we spent the year working with our health department's data center to really look at community health needs and where we could create some collective action to address some of those health disparities. And we were really interested in not just what the data tells us should be our #1 priority, but where there was community energy. And so each of these collaboratives have now selected a focus area and are now going to work on it. And what has been so cool is while this doesn't feel exclusively social determinant of health, it has gotten all of those partners together, each finding something that they're committed to doing. So we're really excited. Got a little delayed last year with fully executing on it. We're really excited to see some good work coming out of this moving forward. The next area that I wanted to highlight for you was around our earliest thing around reinvestment funds. And that I think when Sarah mentioned how often there are grants and you go in and you sort of build the collaborative and you've got the grant and the grant ends and the work goes looking for a new home, and how do we really move into this reinvestment type of cycle. So we were super excited when the Department of Commerce released an RFP for a program called Better Health Through Housing. That really, the intent of the program was to reduce emergency room utilization and get folks who are experiencing chronic homelessness into the set of services that they need. And so we were all about that model, lots of energy around it. But the part that we thought, this is a pilot project, we're going to have to figure out how to move that into a more sustainable model overall. And I am so proud, and I actually see some of the names of folks who are working with us on the call here, but I am so proud of these set of partners who not only are doing good work just with the contract that we have, but are really working to figure out what are our shared outcomes, what is the data that we all agree on, and what's the value to us, so that we're actually practicing this muscle of getting a mechanism in place so that, you know, as we see success with this program, you could really move into a longer term process. So I think that's one of those things that a year from now, I think we're going to have some really great concrete example of how we are shifting the funding into a way that allows this to not be quite so up and down depending on grants and contracts overall. I also think that this is another example of us sort of trying something out, but fits with sort of a continuum of interest that we have around broadband access. And that when we talk about equity, when we talk about social determinants of health, sometimes you just get into the tactical part of a lot of Eastern Washington does not have adequate broadband access. So one of the things that we funded out of our Medicaid waiver dollars is the technical support for local communities to actually build their competitiveness to be able to draw down federal funds. And so we're super excited. Our first grant went in from the Spokane tribe. We put up, I think it's maybe $11,000 for the technical support and the grant writing, and they are in the queue for about $3.5 million of broadband support for the Spokane tribal reservation. So we think this is a really promising sort of just tactical project of a little bit of funds connected to a broader community set of effort to be able to access those federal dollars. Now moving into our strengthening partnerships, and these next couple of slides are really just examples of experimenting that we're doing, and that the Medicaid waiver has really given us a chance to be creative and kind of try things out. So the first is the $2 million that we allocated to support partnerships between social determinant of health and healthcare partners. And we did a couple of things really intentionally with this. One, the applicant was the social determinant of health partner, and they had to have a healthcare partner. And so we wanted to make sure we were sort of messing with the power dynamics. And I know I've got a lot of healthcare friends on here, and you all have great hearts and great missions that you're doing. And you've got a conceived financial model that you're working with. And the way we fund social determinants of health is, you know, a crazy mix of different things. So one of the things we wanted to do with this is try and even up that power dynamic a little bit. And also, we wanted to make sure we weren't creating social determinant of health projects that wouldn't be grounded in what healthcare needs are. And so we're just, we're over the moon about these set of projects that we are working with over the next couple of years that have really taught us or we're at least developing some muscle around how we work together. And anybody who's from Eastern Washington recognizes the names of these and knows these are really, really great mission-led organizations. And it has been really hard to move from the conceptual idea of what our project view was into, really tactical things around workflow, around data share, around outcomes that we're trying to accomplish. So this is another area that I think in another year we're going to have some great reporting on, but has given us a chance to really test this out a little bit. And then I want to end, and I probably, thinking back now, I'm like, I think I wish I'd started with this, but really, you can't talk about social determinants of health without the acknowledgement of racism, institutional racism, and oppression that has occurred. And I think BHT has been, like many of you, on quite a journey over the last year and a half around our role in perpetuating white supremacy culture, as well as our role in helping to dismantle it. And so in June of last year, our board took a really clear position on racism as a public health crisis, and then sort of charged the staff team to start developing programming that has a stronger anti-racism lens to how we do our work. And so that has resulted in our releasing $1.5 million of our community resiliency fund to address impacts of systemic racism. And we prioritized funding organizations that were led by Black, Indigenous, and people of color. So we're pushing ourselves to be more connected to the community and giving more voice to needs that we, quite frankly, were missing. What came out of this are some sort of core themed areas, but the thing that I think we're most energized about it is it brought 19 new organizations to BHT to start working as part of our collective energy. And that feels really meaningful to us because, quite frankly, we were really excited about how deep our set of partnerships were. And what this showed us was we weren't deep enough. And two, the humble approach of trying to learn and being committed to the community voice was really showing through. So we're excited about the work that is before us, both organizationally and regionally, as we move to a more equitable community, and also just some freaking awesome stuff that these partners are working on. I think that's what I got for you.
Great, thank you so much, Allison. And I think I saw a lot of questions and things in the chat that I think this whole presentation by both you and Sarah was freaking awesome. So thank you so much. And wanted to ask a question that I think is on several people's mind, and it starts with Allison, and then Sarah, let's go to you to see if you're seeing something nationally. So a lot of us know that the ACHs were funded out of a Medicaid waiver, and that there's a time frame on that. So how are you thinking about funding writ large, kind of long-term after 2020, 2021? And then Sarah, also what you're seeing other organizations across the country that were basically funded by the Medicaid waiver. So, Allison, go ahead.
Sure. So I think one, I can't help but just make a pitch in case any of you are talking to legislators in the next little bit. We are hoping for a year 6. Washington State has not actually drawn down the full amount of the Medicaid waiver. So if the legislature says yes and CMS says yes, there is a 6th year possible that would allow us to sort of address some of the stuff we got slowed down because we were focused on COVID. So I think there's some longer tail of those Medicaid waiver dollars. Secondly, I think we are incredibly encouraged, me personally, on a variety of levels, that the Biden administration is going to sort of recommit to this idea around social determinants of health and how they affect health. And so some promising, fingers crossed, opportunities for additional waivers and additional ways that the federal government may play some influence. That being said, we really have been thinking a lot about this community hub and how we use multi-sector solutions. And that one of the things that we think is true, we've got a little more testing on this because at this point I do have a lot of money, so that makes me popular with a lot of people. And I don't want to undermine the fact that it's a lot of money that we've had influence over. But the infrastructure that the ACH is playing in terms of being able to work across sectors has felt really important. And I think we're seeing a little bit on just government contracts. We were able to move very quickly on both the commerce contract for better health through housing, on our DOH contract. And so I think our state agencies are saying they can't solve their problems sector by sector. They need this. We offer a mechanism in that way. I think the pairing of our equity and anti-racism work with tactical ways we're trying to solve makes us a pretty interesting philanthropic funded. So I think there's a strategy there. And then I continue to think if we can figure out this reinvestment model where we just take more control locally about how those funds are allocated, reallocated, that has a lot of potential. And it's possible this happens in other parts of the state, but in Eastern Washington and certainly in our Spokane region, there is such a deep interconnectedness of us that I think our partners have been willing to share resources in a more robust way maybe than just in a you have to kind of model.
Almost see you as an amplifier of a broader sort of strategies around the community. Sarah, how would you add to that?
First of all, I just want to say, Allison, I really enjoyed hearing from you, and it was a really good connection to hear about how all these things sort of come together locally. That's exactly what I was trying to paint a picture of at a high level, and so to hear how it's going on the ground was just really great. I think your answer that you just gave to that question was spot on. I just want to build on your point about the Biden administration. You know, Biden was vice president, and many of the staff who are coming to work at the Department of Health and Human Services were there when the Affordable Care Act passed, and then the Center for Medicare and Medicaid Innovation was set up. And I think CMMI, in addition to the waivers, and every state is on a different cycle with their waivers. So yours is nearly ending. Other states, had them before and after you. So there isn't one sort of federal cycle for them. But I think CMMI is going to be a place where the Biden administration is going to want to be inventive about how they use the federal programs to address social determinants of health. And I think the kinds of examples you're giving of how you partner with local entities and how you think flexibly about funding streams while making sure that you have program integrity and you're not opening up to fraud, but are thinking creatively about how you can braid and blend those together so that it's more than just one person at a time, that it's more systemic, I think is something they're going to be really open to, and we'll start early on, and that will give a chance for those to really start to flourish and to be copycatted and amended as needed in other places.
So I think we have time for maybe one more question, which is really, as you think about creating the governance structure for these different community efforts, and Allison, you talked a little bit about this around sort of, it was somewhat legislated and somewhat sort of specific to how you were going to approach the ACHs. And nationally, Sarah, what do you see in terms of how you bring the community, and particularly those BIPOC-led sort of organizations that historically are not at the table? How do you bring that as that group of community organizers and those voices to the governance part of the table?
I think that's a little to be determined for us. I think this first set of funded organizations through our Community Resiliency Fund, we're like, maybe we need to expand our board so that every one of them is on there because they're representing a really important segment of the community. And I would say my board and I are sort of challenging ourselves, like, nonprofit governance has not really evolved that much in the last, I was thinking the 25 years I've been an executive director, but I sort of imagined in the last 100 years or whenever we sort of had that as a mechanism. And so I think there's some real exploration, and we see it a little bit in our collaboratives. We sort of support them, but they drive their own. They have their own network managers and so forth. And so we've been really intrigued to watch this idea around self-governance, and when you build trusting relationships, how the governance structure could look and should look different, and that you end up with a lot of checks and balances when there isn't very much trust. And so I'm really interested in how we further explore that. We've done a lot of work. We've got a community voices council. I think Sarah mentioned, some folks are even paying for that. We pay 100% for the folks that it's not their day job to be engaging with Better Health Together, and think that is one of the ways we even up power in that way. And we've never thought we had all the answers. The answers are going to come from the collective. And so it's pretty easy to be a little humbler in your approach when you really are seeking to understand and be meaningful in that way.
Great. Sarah, what about you? How are you seeing that governance sort of equation change?
It's a great point. And I think what Allison was saying makes a lot of sense to me in terms of not pretending that we have the exact answer yet. The two things that stick out to me is that it's got to be intentional and it's got to be structural. And I think in a lot of cases, historically, it hasn't been. And so there are fewer examples to point to as sort of the shining beacons. But to me, those are two of the principles you've got to sort of follow to make that part of your scheme. And I think looking at a collaborative that's not an accountable community of health, which has, while they all look different, there is a certain structure around them, and there are often requirements at the federal or local level. If you're talking about a collaborative that comes together without that as sort of your scaffold to build on, then you're going to have to probably be even more intentional about it to make sure that you don't just sort of leave out players who don't come with the money or the power to start with, because it's easy to start with those as your basis.
And people that are usually part of those circles. Okay, well, we are at time, so I really want to do a big shout out to both Sarah and Allison for their time today and their presentations, which will be shared. Before I turn it over to Dr. Straley, I just want to remind everybody that this is the first of 4 webinars that were launched based on the work that we did back in November, and want to let everybody know that the next one, which will focus on data interoperability, and there were a lot of questions about that, is going to happen on tax day. How appropriate is that? And so wanted to let everybody know that, to put that on your calendar, and we'll send something out soon about that. And as a way to close, and as something you can do about this and about social determinants of health and taking action, as opposed to just listening and admiring the problem, I'm going to turn it over to Dr. Hugh Straley, who is the chair of the BRIE Collaborative. Dr. Straley.
Thank you, Teresa. I hope people can hear me and see me. One, I want to thank everybody for this wonderful hour and so on social determinants, particularly Sarah, Nick, and Allison for their presentations. I have a better understanding now of the possible opportunities for multi-sector involvement. But I wanted to talk about what you can do, and we will be contacting more and more people and hoping for some sharing and some collaboration around the building blocks for value-based payment. And we all know that costs are important, and the journey to value-based payment is an effort to improve quality, but particularly to reduce our costs and to free ourselves from the being hostage to fee-for-service financing, which has been driving up the cost of care over our history. The 4 elements that we've talked about, and this came out of our value-based summit, which was in November, but the 4 elements are really, can we develop a shared payment model, a common payment model? Can we develop a common metrics and common methods of evaluation? Can we develop a common data set or a common warehouse for information that can be shared and that is interoperable? And can we develop some common tools for evaluating social determinants, as well as common interventions, evidence-based interventions that are reliable? And we heard from Sarah some of the work that is going on to look at these areas, but so far we don't have a critical mass around sharing of these 4 elements. The elements, again, a common payment model, common metrics, common warehouse, common tools for social determinants. So our hope is that we can, through the communities and through the accountable communities of health as well, can we get some collaboration around these in Washington State. And so between the BRIE Collaborative and the Washington Health Alliance, we hope that all of our stakeholders can begin to look at these areas and work collaboratively to establish these 4 elements on a statewide basis. So with that, I really want to thank everybody for their participation, their questions, their involvement, but we still have a lot of work ahead of us for the future. As of yesterday, I'm feeling a lot more optimistic about how we can work together and achieve the common elements in healthcare that we've all been working for better health at a lower cost. So thank you very much.
Are you finished, Hugh?
I'm done.
Okay, great. Well, thank you for those remarks and for guiding us on our steps forward. And thank you to everyone for your participation today. And we hope to see you at our next webinar on April 15th. More information coming, so keep an eye on your inboxes for that. Thanks, everyone.